And Marie Navar, my Gibson, we're talking about the Coral Reef Study. They said PCSK9 by the oral route was undruggable, but you're proving them wrong, Anne Marie. Talk to us about what you did.
Well, I was fortunate to be able to be part of the phase 3 study, the Coral Reef Lipid Study, which I presented at AHA. But a lot of credit to the scientists behind this drug at Merck who were able to develop a an oral PCSK9 inhibitor. So enlicitide is a macrocyclic peptide, and they had to figure out how to get it absorbed. And they figured out if you used sodium caprate, which is a common food additive that is naturally found in dairy products, they could get enlicitide into a pill that you were able to get enough absorption into the bloodstream. And then it works like a monoclonal antibody. So it binds to the PCSK9 protein in the bloodstream and prevents it from interacting with the LDL receptor. And as we know, when the PCSK9 binds LDL, it targets it for degradation. The LDL receptor can't go back up and pull more cholesterol out of the blood. So it's, at least biologically, it looked like a monoclonal antibody, but in the form of a pill. Coral Reef Lipids was to figure out how well it actually worked.
So, how many patients? What was your endpoint?
So the full analysis set was 2,904 patients. That was after excluding five people who never got drug and three people who enrolled in multiple trials. And it was a 2-to-1 randomization between enlicitide and placebo. The primary endpoint was the placebo-adjusted least squared means reduction in LDL cholesterol at week 24, and then secondary endpoint was at week 52. We also had multiplicity controlled secondary endpoints at week 24 of ApoB, non-HDL cholesterol, and lipoprotein A.
And what did you see?
Well, we had to analyze the data two ways. The first way was per protocol, having to treat these five baseline values. Unfortunately, had some lab problems, and because of how we specified things, we had to consider five people in the enlicitide arm to start with an LDL cholesterol of 1.
Mm.
We reanalyzed the data using the Martin Hopkins result for those participants. So we actually have sort of two reports in our presentation. But when we analyzed it per protocol, setting these 5 to 0, we had a 56% reduction in LDL cholesterol at week 24. And when we used the Martin Hopkins for those five individuals, it was 59.7% reduction in LDL cholesterol on enlicitide compared to placebo. So just a really dramatic reduction in LDL, and it was sustained. In the intention to treat analysis, which includes everybody in the study at 52 weeks, the reduction in LDL cholesterol was 52.7% in that reanalysis. So it works and it keeps working over up to a year.
And what's the half-life of the drug?
Ooh, I think the terminal half-life is quite long, Mike, but
So
I don't want to quote
if
you the
you missed a
exact
dose,
number.
well, see, the reason I'm asking is I'm a patient. I take an injectable sub-Q medicine, but I always forget. I always forget to take it. I put it on, my phone says take your medicine, and then I'm too busy. But in oral medicine, I take all my oral medicines every morning. So I'm pretty good about that. So, if someone missed some doses, I was just wondering, would they, it sounds like it would take a while for that to kick in if you miss some doses.
Yeah. So the terminal half-life is like 200 hours or something. It's long on that front, but I'm reluctant to I don't want people to interpret that to mean they can skip doses because we definitely need people to take it every day to have sort of this sustained
I'm all
cumulative
about
effect.
adherence, but I'm also human.
Yeah,
And,
yeah.
you
Then,
know,
but we were worried, and some people more than others about, whether or not a pill was going to look as good as an injectable because you had to take it every day. And enlicitide, you do have to take first thing in the morning after an overnight fast, and then not eat anything for 30 minutes, which is kind of
hmm,
how we tell our patients to take Synthroid. Um, you
mhm.
could take your other medicines with it though. And so there was some concern if people didn't follow the fasting instructions, if they skipped doses, what would happen? Now you're right, we have some wiggle room because of the long half-life. But what I think we found was, Now, with a grain of salt, participants usually over-report their adherence, but self-reported adherence was very, very high. Over 97% of individuals said that they did it correctly 6 or 7 days a week whenever we asked them. But really, the proof is in the pudding, right? The fact that we had this degree of LDL lowering suggests that people were doing it. And my hypothesis is sort of like what you just said. You said, I take my medicines every morning. I think that actually what we thought was a bug of this drug actually became a feature. That
Yeah,
by telling somebody, take it first thing in the morning after you wake up, wait 30 minutes, we gave them a recipe for habit formation. And once they started doing it long enough, it just became baked into their routine.
exactly.
And it was fine.
Yeah. Yeah. Well, those are big LDL reductions. I mean, how many of those people are already on high dose statins?
Well, everybody in the trial in coral reef lipids had to be on at least a moderate intensity statin or
Moderate.
have documented statin intolerance. We had 97% of individuals in the overall trial were on a statin. And then of those, uh, well over half were on a high intensity statin. We also had about 26% of individuals were on ezetimibe as well. So there was a reasonable amount of combination therapy. So pretty good treatments, but in spite of that, the LDL, average LDL cholesterol in the trial was still 96 milligrams per deciliter. So, really
Wow.
highlighting that a lot of our patients, even on good background therapy, just are not getting to goal.
Not anywhere near target. And so at the end of the day, Emery, after this 55, 60% lowering, where did people end up? What was their mean median LDL?
Yeah, so at week in the primary analysis at week 24, the mean LDL cholesterol for the enlicitide arm was 38.7 milligrams per deciliter, and
Wow.
at week 52 is 45.7 milligrams per deciliter. Just,
Yeah.
it well under that 55 milligram per deciliter goal
Yeah.
that
Do
we
you
we
think
were looking
45
for.
is going to be the new 55? I mean, with the results of Azaleas hitting that
I
kind of number, do you think we're going to drive it down to 45 as the new target?
I sure hope so.
Yeah.
I think if we target less than 55, we will get well below that.
Yeah,
It's hard to, when we say 55, it's not 55 on the nose, it's less than.
correct.
And just the data are so consistent and compelling that lower is better, and you don't have to have a prior heart attack or stroke to benefit from lower LDL cholesterol, particularly over many years. I think Vesalius is just game changing.
I do too. I really do. What do we do with cholesterol denialist? How do we combat that?
Well, part of it is I think we need to do a better job of getting our message out. We spend a lot of time talking to each other at these meetings and relatively less time talking to the public. Um, there are people who are never gonna want to take a cholesterol drug, but when we've looked in big registry studies amongst people who are seen regularly by physicians, the vast majority actually reported that they would be willing to take cholesterol lowering drugs. But when we asked why people were not on things like high intensity statin in the Palm registry, the number one answer was nobody had told me I needed one. So while it's a big issue, the cholesterol denialists, I actually think the bigger issue is just the therapeutic inertia that we have, and that we're just not even getting to the people who would be willing to take the drugs in the first place. We looked recently and earlier this year published a paper showing that almost 4 in 10 cardiologists have never prescribed a monoclonal antibody PCSK9 inhibitor, and well over 95% of primary care doctors never prescribed one.
Wow. Wow.
That's not the denialists that's the problem. It's that we're just not using the tools that we have at our disposal.
Yeah. I mean, even my doctor, Harvard trained, former Harvard chief resident, my calcium score was high, my LP little a was high. First of all, I had to push to get my LP little a tested. My LDL was 70, and yet I had a high was score. I said, well, maybe we should test this LP little a. He said, LP little what? And then he said, well, your LDL 70, maybe we should back off. I said, what are you talking about? He said, well, there's people, who say that the lower is better hypothesis is wrong. and that people with high cholesterols are living longer. So there's just so much misinformation, disinformation out there that really is even affecting doctors, not just
Yeah.
patients.
And and part of it, I think, is also on the publishers, that when a journal publishes a highly confounded observational study that is full of survivor bias, then, the press is going to pick it up as if you're 90 and have high LDL, you're going to live longer. Well, you have some number of resilience factors that got you there in the first place. We're not considering everybody who died in their 50s of a premature MI from FH. Um,
Right.
but the messaging here is
It's
just
horrible.
terrible. That's why I
Yeah.
really like Vesalius. It's like for you, right? In that situation,
Correct.
you
There's
would have you're a
millions of people
perfect
just like me.
Vesalius candidate,
Yeah.
right?
Yeah.
And I think now we have not only definitive evidence that PCSK9 inhibition with really big reductions in LDL cholesterol in people with a lot of athero do better. I mean, they died less. And,
Yeah.
with the asterisk that they didn't get the order right, um, the
Please
mortality was less in people who got
spare
this
me
drug.
that the statistical purists who just got off the statistical Mayflower can talk all they want, but for my money, it's more of a Bayesian. Looks good to me.
I
My
agree.
LDL's 19 and I'm proud of it. So there you go.
That's amazing. My hope for this drug is that it's priced in a way that it is affordable and that the insurance companies actually cover it. There is a fear by many drug companies that if they don't price the drug high enough, that the PBMs aren't going to make enough money on their rebates and discounts, and they're not going to cover it. And my hope is that we can that this drug is priced in a way that can take that on and not only improve access for patients, but actually get people more comfortable prescribing. I think it's easy. I don't want to over seem like I'm scolding my colleagues for not prescribing the injectables because the reality is you have to know how to do it. You have to know what the pen looks like and how to tell patients about it and how do you manage injection site reactions. When I've got 40 minutes for a new patient and the only thing I'm talking about cholesterol, 5 minutes to talk about an injection isn't a big deal. But if I'm a primary care doctor and I've got 20 minutes and I got to cover you head to toe and do everything else that I'm expected to, it's a lot. So my hope is that this pill is not going to be so overburdened with PAs and it's not going to be so expensive that primary care doctors are going to feel much more comfortable prescribing it and they're not going to have their hands tied. So we'll have to see where things pan out, but I'm optimistic that at least the data suggests that this is a drug that could have a huge population impact if we can actually get it to the patients.
I agree. I think we focus sometimes on the wrong P. The first P is the P value, but it doesn't stop there. The next P we should be thinking about first and foremost is the patient value. The next P value is the public health value. We should not be thinking about this last P, the PBM value. That is the tail wagging the dog. We got to get our Congress to get rid of PBMs. I'm sorry.
Yeah.
Yeah.
Well, and look, the final piece, the prescriber, right?
Yeah.
I don't get any, why do I have my full-time nurse spends most of her time doing prior
The
authorizations.
approval. That's
She
the other
could
piece
be,
on prior approval. Yeah.
yeah, she could be calling patients and seeing them in follow-up and doing education, but instead she's filling out forms.
Yeah.
It's
It's broken.
it's not sustainable.
Well, the last P is I call it the PCSK9 inhibition. After you have a PCI, it is a moment where you can impact someone. And we got to do a better job, particularly on secondary prevention, or even if you have athero and we see it on the angiogram, some primary prevention. I still think that. I know there's a lot of debate. Is it really primary prevention? I'm going to call it primary prevention, getting someone on treatment before they have the event. But we got to do a better job among our own cardiologists, in particular interventional cardiologists. Yeah.
I agree. And I think the interventional cardiologist can be really helpful when they tell the patients, I've opened up the one lesion, but you've got plaque throughout your coronary tree. And it's actually been our interventional colleagues that have done some of the most compelling research for us, showing that when we get LDL cholesterols less than 55, we start to see plaque regression.
Yeah.
When the patients say, well, doc, can't you go in and roto-rooter out the plaque? When they say, no, but I can put you on medicine and let your body do it yourself, that's really empowering to the
Yeah.
patient and really motivating. So I think you're right. But I'm fortunate that I have a lot of colleagues in interventional cardiology who understand the importance of this too. So,
Yeah. We
uh,
need to do a better job.
yeah.
Anne Marie, so great to see you as always. Thanks for, educating us. I learned a lot today. Thanks for all that you do. And thanks to all of you for joining us here live from AHA 2025.
Thank you, Mike. It's always a pleasure. And thanks for helping combat the misinformation, doing what you do, which is educating our peers and educating the public about these new therapies and what we need to do to really make an impact at the population level.
Thanks. Thanks, Anne Marie.